Hello, and welcome to the Cardiology Podcast, Why We Do What We Do in Cardiology. In this audio series, we will discuss the practice-changing articles in cardiology from the past to the present. This is your episode for today.
Today, I will discuss about some of the key takeaways from the latest state-of-the-art review on a practical approach to left main coronary artery disease. Main author is Laura Davidson from Northwestern University, Divisions of Cardiology and Cardiac Surgery in Illinois, USA. This article was published in the Journal of American College of Cardiology in November 2022. In stable patients, there is most evidence that revascularization helps people with left main disease live longer than medical treatment alone. But figuring out the best way to treat left main disease is a hard decision. Recent clinical practice guidelines give clinicians some direction, but it is still hard to decide how to treat an individual patient. The Cardiac Surgery Team and Interventional Council of the American College of Cardiology worked together to devise a practical way to treat left main disease by looking at different randomized clinical trials, meta-analysis, and clinical practice guidelines. Due to the complexity of left main coronary artery disease, which is rarely found on its own and is often found with other types of heart disease, a treatment algorithm is proposed that includes medical therapy alone or in combination with either PCI or CABG. Left main CAD can be categorized into either ostial or shaft disease and distal disease. And in presence of multivessel disease, things can make often worse. Along with clinical practice guidelines, clinical, procedural, and institutional factors should be taken into account when choosing the mode of revascularization for patients with left main disease. Ad hoc interventions are not recommended for people whose disease and symptoms are stable. It is recommended to use a heart team approach that takes into account clinical, procedural, operator, and institutional factors and includes shared decision-making that takes into account each patient's needs, preferences, and clinical situation. In case of diabetes mellitus, complex multivessel disease, significant LV dysfunction, concomitant ascending aortic or valvular disease, recurrent prior stent failure, anatomy unlikely to achieve complete revascularization with PCI, and contraindications to dual antiplatelet therapy are all the things that could make CABG a better option for left main coronary artery disease. Whereas significant obstructive or restrictive lung disease, advanced age, clinical frailty, severe chest deformation, porcelain aorta, side effects of previous chest radiation, poor surgical conduits or bypass targets, barriers to postoperative rehabilitation, STEMI, or cardiogenic shock are all the things that may be in favor of PCI over CABG for left main CAD. Left main CAD may be better treated with medical therapy if the patient has a lot of severe health problems, is very weak, has a short life expectancy, and knows what he or she wants. Notably, the best revascularization strategy for a given patient depends on the expertise, experience, and results of the specific surgical and interventional teams at a given institution. Thank you.
Thank you for listening to this podcast, Why We Do What We Do in Cardiology. The information in this podcast is for general information only for medical professionals and is not intended to be a substitute for medical advice from a qualified healthcare professional.
We hope you found this information helpful, and we look forward to seeing you on the next episode.